Asian pharmacists, or both our interns, sorry, and our clerks. So today, hopefully, will be a fruitful afternoon or fruitful morning to afternoon. And just like Ma'am Marge said, we'll have a post test at the end of the day. Um, all right, so let's start. I think we can start na Ma'am Marge, and the rest will follow na lang po. All right, okay. So our first topic for today will just show the overview of the clinical pharmacy practiced here in Asian Hospital. But before that, let me introduce myself. I am, again, Angelica Martin. You guys can call me Ange. I am a graduate of the University of Santo Tomas, BS Pharmacy, major in clinical pharmacy, and I've been with Asian for almost 4 years next month. So I have served as a staff clinical pharmacist here in Asian for 3 years prior to moving towards the admin side. And my one true love is the operations. So I really did enjoy being able to serve as a clinical pharmacist here. And minsan may time to, nag-staff din or nag-duty din ako from time to time para hindi masyado maging rusty when it comes to the updates on the guidelines or updates on interactions, updates on anything that I need to remind myself about or refresh when it comes to, again, the practice of clinical pharmacy. So I'll get right to it. The objectives for today or for this specific presentation is to understand the practice of clinical pharmacy, to appreciate the process of medication appropriateness check, which again is the bulk or the major responsibility of clinical pharmacists here in Asian Hospital, to know the proper development of a pharmaceutical care plan, to actually this one it's just more of an overview, yung mas in-depth development of the pharmaceutical care plan I will reserve for our clerks on March 2, if I'm not mistaken, and to recognize the drug information resources we use to come up with these plans or with our recommendations, to promote a culture of safety in the workplace, and to give a brief overview on the antimicrobial stewardship program. I'll just touch a few things on the AMS program in this presentation, pero we'll discuss it in depth. I think that would be my last presentation around siguro mga 4 o'clock dun natin itatackle yung program on antimicrobial stewardship. So I am hoping for all of your focus and participation for today's session. At any point in time, you can raise your hand if I'm speaking too fast, because I have the tendency to speak really fast. And if you want me to pause for a while so that you can take down notes, let me know. If you have questions, you can let me know. You can chat, you can type it in the chat box or raise your hand, and I will do my best to answer your questions. Shall there be no participants, or shall no one answer any of my questions, because I will from time to time ask some questions. I do have a randomizer prepared, so meron akong roleta dyan. So kung ayaw niyo participate, I will choose someone, or the randomizer rather will choose someone to participate and answer my question. All right? Okay. So just a brief background, which I think you've already probably encountered or probably know already from the hospital orientation, is that we were established on May 11, 2002. So we're about 21 years old, and we are a premier tertiary hospital accredited by the GCI. So we have just bagged our 4th gold seal last September 2022 as one of the most advanced healthcare institutions in the Philippines. So Asian Hospital, I want to ask actually my first question. If you guys remember the core values of Asian Hospital and Medical Center. So ready na yung randomizer ko kung walang mag-raise ng hand. Does anyone remember the core values na mention ba? Yes, Miss Justine. Sige. Ma'am Kat, I'll reserve one more question for you. Yes, Miss Justine.
Fairness, integrity, teamwork, excellence, and respect.
Thank you. Exactly. And it's already written on the screen. Thank you very much. My question to you, Miss Kat. Miss Kat, I understand, yes, you are our intern from the University of the Philippines. My question for you is, what do you think is the most important core value for yourself, as a pharmacist? And why?
Ma'am, for me, integrity.
Okay, why?
Um, I think, ma'am, with integrity, that would follow dire-diretso na po siya. It matters na you are a role model. Even at the back, are you doing well? And with that, there comes my fairness. And with integrity, we become leaders as well. And with that, papasok na din yung teamwork dun. And with, because being a person of integrity, kasama na rin po yung respect to your colleagues and even to your clients, your customers. And with integrity, then that would be your inspiration for you to be excellent, in your profession.
Thank you
Yun
so
lang.
much, Ma'am Kat. Thank you so much, Ma'am Kat. That was a wonderful answer, and I couldn't have said it better myself. I agree. But again, there is no right answer in this sa kung ano yung pinaka-importanting core value sa inyo. What's important is that you actually practice or encompass all of these core values. So thank you so much, Ma'am Kat. I agree with you. Integrity is also one of the most important core values for me, because just like you said, everything else will follow after that. So thank you, Miss Kat, and thank you, Miss Justin. Miss Kat and Miss Justin. So I'm taking note then of your recitation and your participation, and maybe your forced participation if you do not answer, if no one wants to answer my questions. Miss Justine. Okay. Next slide. So I also think that na-mention sa inyo yung mission and vision of the hospital. So of course, our goal as your choice of site for internship and clerkship is as much as possible to provide you guys with a great learning experience and something and a culture that you feel you're safe to work in, and provide a learning experience that you would want to continue on, especially once you graduated, for example, BS Pharmacy, or once you finished your Doctor of Pharmacy degree. Our goal is to absorb you guys and to ensure that, again, we provide you with an experience that would hopefully encourage you guys to join us as well. But because of that, you have to also align. You have to know the mission and vision of the hospital and know if your goals align with them as well. So the mission of Asian Hospital is to deliver accessible, world-class, compassionate, and integrative healthcare service to every individual. And if you also envision to be part of an institution that will be the center of global expertise in caring for the unique needs of our patients and the communities we serve, we hope to see you as well. And once you guys have graduated, once you guys have passed your board exams, and hopefully we get to work with one another. I have a chat here. Okay. Si Ma'am March lang pala. All right. So moving on. So what are the responsibilities of a clinical pharmacist in general? And this is also something we practice here in Asian Hospital. So we are responsible for ensuring rational, safe, and cost-effective drug therapy in collaboration with doctors and other allied healthcare professionals by, of course, providing our recommendations or referrals for appropriate drug product selection, effective regimen design, and optimal drug therapy monitoring services, of course, to achieve the best possible health outcomes, or in short, to improve the quality of lives of our patients in any way we can. So how do we develop a pharmaceutical care plan? So we have 5 steps to a pharmaceutical care plan. But first, let us define pharmaceutical care. And I know this term has been defined over and over again in BS Pharmacy and probably in clerkship as well, and for our clerks as well, or our Doctor of Pharmacy students, that it is the direct responsible provision of medication therapy for the purpose of achieving definite outcomes that improve a patient's quality of life. So we have the 5 steps. Let's take note of this. So we have collect, assess, plan, implement, monitor, and evaluate. So I will discuss each step along the way. All right. Any questions so far? So the first step is to collect. So what do clinical pharmacists collect? We collect the necessary subjective and objective information about the patient so that we can better understand the relevant medication or medical history, and the clinical status of the patient. So what you can see here actually on your screen is an example of our CP patient profile, or our patient drug profile. So here every admitted individual here in the facility has their own patient profile. So what does it include? It includes the patient demographics of the patient, from the name, the hospital number, the birthday, the height and weight, the diagnosis, the allergies are very important, um, whether female or male, the age, and the admission date, and of course the room number. So what is included here as well are the medications on board, the standing medications on board, as well as the as needed, or the PRN medication. So we have a lengthy or informative structure when it comes to showing what medications are on board. And to your right, we see the history of the medications while the patient was admitted. So whether it was increased or decreased, whether it was shifted, completed, and whether if it was put on hold or discontinued. So we have that kind of a medication history per patient, again, admitted in the institution. Not only do we monitor the medications that are on board, but we also monitor the lab parameters, because this is what we use as basis for our referrals, on top of course, our drug information resources, but this is patient specific. So we know how the trend, at least, of the infection, for example, by looking at the CBC, looking at cardiac parameters, whether the patient is improving or regressing in terms of renal function. So we have an in-house calculator here that will compute the creatinine clearance and the EGFR, determining your renal function. Then we also monitor our serum electrolytes such as sodium, potassium, ICA or ionized calcium, and the rest. And to your right, we also have the culture and sensitivity results. So we use this to check whether a patient has a growth on a specific specimen, and if there are certain antibiotics that are resistant or susceptible, again, depending on the specimen. So if, for example, a patient is on ampicillin sulbactam or let's say cefuroxime for UTI, and you check the specimen that was taken from the patient is the urine, and you saw from the final culture and sensitivity results, the patient is resistant to cefuroxime. So this is where the clinical pharmacist will come in and refer to the doctors that, okay, we have all of this information, and then the next is what we're going to do about it. So we recommend to either shift to a different antibiotic set, or at least inform them that the patient is resistant to cefuroxime, because again, what is the point of giving an antibiotic if the patient is resistant to it, right? So yeah, that's one for culture and sensitivity results. Then we have for gram stain, acid fasting, and we also monitor chest x-rays, especially if the patient is, you can see the trend of the pneumonia of the patient, for example, if it's regressing or progressing, as well as for urinalysis, fecalysis, and other tests. So those are the things that we monitor, those are the parameters we monitor, or the data that we collect in order to come up with a pharmaceutical care plan. So like I said a while ago, we collect all of this information. So what's important is we have a system that provides us with all of this information, and that is from our hospital information system, or the Orion. So it provides all of that data. It provides the medications on board, at least those that are scanned, as well as the lab results per day. And now we have all of this information. The next step is to assess all of this information, because there is no point, or it's a tedious process of collecting all this information and doing nothing with it. So we have to assess the information collected and analyze the clinical effects of the therapy in the context of the patient's overall health goals, in order to identify and prioritize the problems and achieve optimal care. Because as pharmacists or clinical pharmacists, we have a function of identifying potential and actual drug-related problems, and resolving the actual drug-related problems, and preventing the potential drug-related problems. Okay, so after collecting, we assess. Then after assessing this information, we have to start planning. So we have to develop an individualized patient-centered care plan, meaning one therapy or one medication may work for this patient with this indication, but it might not work for another patient with the same indication. So you have to take into consideration, it has to be tailored to each patient, because different patients have different renal functions, different patients have different comorbidities, different risk factors. So it really does have to be tailored to each patient. Again, this is in collaboration with other healthcare professionals and the patient, for example, during patient counseling, or caregiver, that is evidence-based and cost-effective. So everything that we plan out has to be evidence-based and, of course, cost-effective. Next is, so once you've collected the information, we have already assessed the information. Okay, we know what to plan, we know what the plan is, and now we have to implement the plan. And then again, of course, we have to implement the plan in collaboration with other healthcare professionals, the guardian, the caregiver, or the patient, him or herself. So how do we implement plans, at least for clinical pharmacists here in Asian hospitals? So we implement plans through clinical pharmacist monitoring notes, which I will talk about later as well. It's more on our communication tool with nurses, with doctors, on our specific recommendations, kung ano yung problem, ano yung situation, what we assessed from the data that we collected, from that interaction, or from our specific plan for the patient, and the recommendation thereafter. So we have to implement this, and we implement this also through calls, depending on the severity or urgency of the concern. Kung hindi mo na kaya mag-CP notes or i-send yung file to the patient chart, or to attach the document to the patient chart, we call agad, especially if it's urgent, if it's something that we think that can be addressed right away. So this is again in collaboration with other healthcare professionals. And for patients, again, during patient counseling, for example, implementing a timing of the timing of administration of medications, when to take these medications. So you implement a time or a schedule for them based on their everyday living. So how they start their day, what time they start their day, what time they end their day, and you have to tailor it to their lifestyle. So that's how we implement. And then next, once we've implemented that, once it's been acknowledged, once it's been accepted, once the medication order has been revised based on the clinical pharmacist recommendations, we don't stop there. It is a cycle. We continue to monitor and evaluate the patient. So we evaluate the effectiveness of the care plan, because today, for example, I referred a medication based on the renal function of the patient. And the next day, when I was updating the patient's profile, gumanda na yung creatinine clearance. So maybe it's time, again, you have to look at all the parameters as well, not only kidney function. If for antibiotics, you look at the chest x-ray, if it's for pneumonia, UTI, if it's urinalysis, if it's UTI, and as well as you can look at the trend of the CBC and check if all of these parameters or all of these criteria point towards increasing or decreasing a dose. So again, what may be okay for today, or what may be appropriate for today with regards to the medication on board, may not be appropriate the next day anymore. So this is why we have to continue monitoring the effectiveness of the care plan and modify it accordingly with, again, collaboration. So we hear collaboration a lot because, again, we are part of the healthcare team, and we have to collaborate with the other professionals on the healthcare team, may it be doctors, may it be nurses, may it be respiratory therapists, nutritionists and dietitians, physicians, medical residents. All of those we have to take into consideration when we start implementing our plan and monitoring and evaluating afterwards. So those are the 5 steps. I want to hear from someone if they can recap what are the 5 steps of the pharmaceutical care plan, if I made any sense the last couple of minutes. Is it time to use my randomizer? Ito na, randomizer. Oh, si Miss Dayan first ata. Yes, Miss Dayan.
First po is collecting.
Sorry?
First po is collecting.
Collect. Okay, that's great. Then next,
Assess.
Okay, assess, and then?
Plan.
Uh-huh.
And then implement.
Uh-huh.
Last po is monitor and evaluate.
Evaluate. Okay, thank you so much, Miss Dayan. Dayan. All right, thank you so much, Miss Dayan. All right. Now, any questions before I move on? For me, did I make sense naman sa sinabi ko kanina? Naintindihan naman, was I going too fast or okay lang ba? Can I have a thumbs up if everyone understands what I just said the past couple of minutes? All right. Okay, thank you so much, guys. Now let's start off with let's continue with the medication use process. So it starts off with prescribing. So prescribing, syempre, it is our doctors who prescribe the medication regimen for the patient, followed by preparation. So sa preparation kasi, well, after prescribing, di ba, transcribe, and we talked about that earlier during your recap with Ma'am Marge. So after transcribing, it goes to the preparation. So yung preparation kasi, dun papasok yung review of the clinical pharmacist prior to dispensing. So again, the next phase or the next step is dispensing, followed by administering. So this is from the nurses side, followed by monitoring, which is also a collaborative team approach. Everyone has a role in monitoring, whether it's the doctor, the nurse, as well as pharmacists. See, clinical pharmacists also monitor for adverse drug reactions, especially when reading, for example, the scanned documents to us, and mapapansin namin na, okay, with allergic reaction or experienced difficulty of breathing with this certain medication. So it is our responsibility to inform or to remind our nurses or residents to accomplish the adverse drug reaction form. So at least this is reported to the FDA directly through our online portal. Okay. And because of that, once we see that the patient, for example, is allergic to a certain antibiotic or certain medication, so the history or the medication should be reflected on our hospital information system that the patient suffered a certain, let's say, experience an allergic reaction to the certain medication para ma-prompt siya sa Orion or sa hospital information system next time you dispense a medication or next time an inpatient pharmacist transcribes a medication. Good. Now we will move on to pharmaceutical calculations. So I hope you guys have calculators ready, because I think I have about 2 questions here or 2 cases here that would require mental arithmetic. If you guys are okay with that, or if you guys want to use your calculators, go lang. So I hope, or if you have a pen and paper, that's fine with me. Okay, so why is pharmaceutical calculations important? It's not only important for clinical pharmacists, it's also important for inpatient pharmacists, for UDS pharmacists, for compounding pharmacists, for the whole pharmacy. And I actually have oriented a lot of my newly hired clinical pharmacists and inpatient pharmacists that thought na, okay, papasok akong pharma yung pipiliin kong course kasi walang math. Ako, I didn't really think of that because, to be honest, this is my favorite subject. Pharmaceutical calculations and math is my favorite subject from college and in high school. So this is important because we have to be able to dispense drugs in accurate concentrations, calculate correct doses, and compound and prepare medications accurately. So as to ensure that each particular drug is being administered correctly. So, sino sa inyo yung nag-isip na walang math sa pharma at nabudol kasi wala daw math sa pharma? Meron ba sa inyo? Or alam nyo lahat na may math sa pharma? Wala ba? Alright, sige. Okay, let's move on to the equivalent measurements, or what we usually observe na dumadaan sa amin na orders or things that we think equivalent measurements that I believe will be helpful for you guys, especially in the next slides where I'll show the case wherein we will start computing. So we have teaspoon to ml, tablespoon to ml, liter to ml, just basics talaga. Milligram to microgram, gram to milligram, kilogram to pound. So I'm pretty sure most of you have tackled this already. And okay, I'll proceed to my next slide, which is the case. So I will not accept volunteers anymore because I want to use this randomizer. So the doctor orders paracetamol 15 milligram per kilogram by mouth every 4 hours as needed for fever, and the child weighs 44 pounds. Our preparation available here in the pharmacy is a 250 milligram per 5 ml syrup. How many ml per dose must be given to the patient? So I'll give you a minute or two to calculate. I will calculate also. Pero sige, I'll accept volunteers. I want to hear someone from the clerkship or the doctor of pharmacy students. Okay. Doctor of pharmacy. So I have a randomizer here. If no one will raise their hand in a minute. Okay, wow, that's great. See, Sir Forter. Porter, am I saying it right? I'm sorry.
Yes po.
Correct me. Okay, all right. Let's go, Sir Porter. What's your answer?
So, bali 300 milligrams ng paracetamol for 44 pounds ng sakit.
Yes, 300 milligrams, but the question is how many ml per dose? So what is the equivalent ml, Sir Forte? Yes. Mental arithmetic yun ah.
Wait lang po.
Sige, go lang. So I'm glad Sir Forter said that. He said 300 milligrams. Okay, so since you answered already, Sir Forter, and thank you so much for that, can I have someone else from the clerkship side? Kasi yung next case, ano naman, BS Pharma naman yung sasagot. Yes, Miss Ken.
6 ml po.
6 ml. Okay, great. So thank you so much for that. Let us see the answer. Was everyone able to answer the question? So yan, simple ratio proportion lang. So again, how did we get this? How did we get 6 ml? So 44 pounds, we just convert the pounds to kilograms and then get the desired dose in milligrams by multiplying the weight by the prescribed dose or the prescribed recommended dose, and then when you get the desired dose in milligrams, you just do simple ratio proportion with the stock dose available. So thank you, Sir Porter, and Ma'am Ken, you can lower down your hand unless you have a question. May question ka ba, Ken? Wala. Sige.
Wait lang, sorry po.
Okay lang. Sige lang. Okay, thank you. This is the next case or next activity, and I will ask for volunteers from DBS pharmacy side, but of course, this is also a practice for our PharmD students as well. And I think this is pretty easy already. So calculate the dose of cefixime suspension in ml. So again, your answer should be in ml per dose for the urinary tract infection in a 1-year-old patient weighing 22 pounds. So again, so pediatric case to. So most of the medications for pediatrics are weight-based. So the recommended dose is 8 milligram per kilogram per day, divided in every 12 hours, and the available suspension in the pharmacy is 100 milligram per 5 ml concentration. And nice to know about this activity, actually this specific case, ginamit ko din kasi to sa mga BS Pharma or inpatient pharmacists, newly hired inpatient pharmacists, and clinical pharmacists. And apparently, hindi parang once or sa daming beses kong pinakita tong slide na to, once or twice lang, or once lang, 1 or 2 people na tumama sa activity na to. So let's see if our BS Pharma students will take a whack at it and get the correct answer. No pressure, no pressure. So interns, I think I have for interns here. Yeah. Does someone want to answer the question? Kung meron. Mabilis ba masyado? Sige, I'll give you another minute. If not, I will choose someone so that I can finally use my randomizer. This is the glitch. Anyone? Okay, Miss Sam. There you go. Thank you, Miss Sam.
Ma'am, try lang po, baka mali. 4 ml po.
4 ml per dose or 4 ml per day?
Nakumpute yata ma'am per dose. Hindi po
Your 4
yan.
ml is per day ba? Or per dose?
Ma'am, ang nakompute ko po yata yung per dose.
Per dose. So, yun naman yung tanong ko eh. Calculate
Okay.
dose in ml. So, this is per dose. So, tama, 4 ml yung sagot. 4 ml per day. Per dose, sorry. Anyone else have a different answer? Kasi hindi ko pa pala nako-compute. Ako naman magko-compute. Sandali. Anyone else have a different answer? Everyone else is 4 ml? Okay. I will ask another one from the clerks. Anyone else have a different answer? Everyone? Kahit sa clerks, same answer, 4 ml per dose.
Wait lang po.
Okay. Ito pala. Meron ng randomizer ng clerks now. I want to choose someone. Sensil, Sir Cyril. Is he here?
Yes po.
Yes. What's your answer, Sir Cyril? Is it the same, 4 ml per dose?
2 ml per dose po.
2 ml per dose. Oh, okay. Thank you, Sir Cyril, for that. Okay, Sir John is here. Okay. So let's compare the two answers. So Miss Sam said it was 4 ml per dose, whereas si Sir Sensil, said that it was 2 ml per dose. So let's see. Okay. So tama naman si Ma'am Sam. It is 4 ml, but it's per day. So tama si Sir Cyril na 2 ml per dose. Bakit? So again, we convert pounds to kilograms, and we got 10 kilograms. And then we multiply it by the desired dose, which is again 8 milligram per kilogram per day, no longer dose. So you have 80 milligrams per day. And then, yun nga, every 12 hours kasi binibigay yung medication. So you divide it by 2 and you get 40 milligrams every 12 hours. And what we're asking is for the ml equivalent. So again, ratio proportion with the stock dose available, you get 2 ml every 12 hours. So yun yung difference. Thank you so much, Sir Cyril. And Miss Sam for the participation. Okay. All right. Pwede na kayo huminga. Wala nang calculation. Mamaya-maya na ulit. So let's discuss the clinical pharmacy functions, or the functions of our clinical pharmacist here in Asian Hospital. So this is just an overview, and I'll go right into it per function in the latter slides. So medication appropriateness review is one of them, again, as I mentioned a while ago, or medication appropriateness check is one of the major functions of a clinical pharmacist here in Asian Hospital. And later, I'll give you ano ba yung mga criteria na minomonitor namin? Ano ba yung mga parameters that we have to monitor in order to review medications that are appropriate or inappropriate and refer accordingly. We also do therapeutic monitoring, and this is part of the 5 steps nga po ng pharmaceutical care plan, di ba? We continue to monitor and evaluate the implemented plan and the progress of the patient, as well as antimicrobial stewardship. So we are promoters and advocates of our antimicrobial stewardship program, which I'll discuss in a bit. We respond to medical emergency codes. And again, later I'll discuss kung ano ba yung mga codes na, what are the codes you respond to in the hospital. We are a provider of medication information or drug information, and we'll discuss what are our resources, what are the drug information resources we use. We monitor adverse drug reactions, like I mentioned. We participate in continuous training and further education. So training clerks, training interns, training newly hired inpatient pharmacists and clinical pharmacists, as well as We are a big advocate of patient safety. So this is not only a function that should be applicable to clinical pharmacists, but to all pharmacists, or actually everyone, all healthcare professionals, because we all have a role to play in patient safety. So let's start off with the pharmacy. So for example, how can you be an advocate of patient safety as an inpatient dispensing pharmacist? So, as a pharmacist, I want to beat the stigma kasi we hate it when we're called as people who just dispense medications. We hate it, and we don't want to live up to that stigma, or to that how people perceive pharmacists. Just taga-benta lang yan taga-dispense lang. I have huge respect for those in the community pharmacy, and even here in the hospital pharmacy. So your role as an inpatient pharmacist is to check, or at least cross-check, the allergies of the medication. Again, the difference between clinical pharmacy, doctor of pharmacy, and inpatient pharmacy are the number of years you studied, but you all have the same pharmacology background. Mas in-depth lang din siguro yung for clinical and for PharmD. So again, as an inpatient pharmacist, how do you be an advocate of patient safety? Again, you cross-check the allergies, and that's the least you could do already as a pharmacist, because you have to cross-check whether the medication prescribed has a possibility of having a cross-sensitivity reaction with the allergies of the patient. And also after that is the quantity to be dispensed. So if you dispense more than you're supposed to be giving, it's possible that the nurse might give an extra dose, or if you give less than what was required, it might conclude, or it might result to an underdose, so something like that. So all of these we take into consideration, because we have to always remember that at the end of the line, or at the end of our process, there will be a patient receiving the medication that you reviewed, whether it's from inpatient pharmacy, clinical pharmacy, the checker, all of that will follow. So always remember why you're doing what you're doing and who you're doing it for when you process medications. Don't do it just because it's a job, but do it because your patient also is relying on you to perform your responsibilities, and because most of you have taken already an oath to serve your patients well. And it's not only doctors who serve our patients well, our nurses, although we are not as recognized, we are in the background. We still have a role. All of us have a role to play in patient safety. Okay, nag-TED Talk na pala ako nun. Okay, next is multidisciplinary rounds in ICU. So we participate rather in multidisciplinary rounds in ICU, meaning this happens twice a week, Mondays and Fridays. So the clinical pharmacist, or the senior clinical pharmacist, goes to the ICU and it participates in the rounds of each patient. So they discuss. The team consists of intensivists, nutritionists, respiratory therapists, residents, nurse, and the pharmacist. And I think there are some more. But what you do is you discuss each patient's case. So for example, if there are 10 patients in the ICU, MS pa lang, medical surgical ICU, 10 patients, you will go through all those 10 patients and discuss concerns, or recommend your interventions as needed kung meron man, kasi the intensivist will give you the floor to speak, especially if you wanna share your referral, share your recommendations, or your perspective of the case. Sometimes it's like that there. So it's great to be part of a team that hears you out and that acknowledges your presence as a vital member of the healthcare team. Kasi yun nga, we get to be a voice, or serve as the voice of the pharmacy once we're on the floors. So kung availability man yan, sa amin din itatanong. If there's an interaction that can be avoided, what are our recommendations based on the case, especially if there's an untreated indication, ano ba yung recommendation namin as a clinical pharmacist? Or if there are certain medications for adjustment, dun din namin nire-raise. Yun. Next, okay, so moving on to each function. So we'll talk about medication appropriateness check. Again, this is the bulk, or the major responsibility, again, of a clinical pharmacist. Now, these are some of the criteria, or most of the criteria that we monitor, or that we take into consideration when we review medications for appropriateness. So we take into consider demographics, patient demographics, allergies of the patient, of course, drug and dose, route and frequency, weight and other physiological information. Kasi especially for weight, whether or not pediatric or adults, so for pediatric cases or pediatric patients, syempre, again, like I mentioned a while ago, most of their medications are weight-based, and we need the weight as well of adults in order to compute for the creatinine clearance kasi kasama siya sa Cock-Rolf growth equation. Yan. And then other contraindications, for example, a patient is pregnant, kung may renal dysfunction, yun, those are contraindications that we can take into consideration. Therapeutic duplication, drug-drug interactions, drug-disease interactions, drug-food interactions, and variation from organization criteria for use. So part of variation is off-label, compassionate use, non-formulary use. So all of this we take into consideration when deeming medications appropriate. All right, I'll move on to my next slide. So this is just a short scenario on how important medication appropriateness check is. So for example, a critical patient is currently on several medications, and the nurse, usually ito yung mga inquiries, they will contact the clinical pharmacist. Ma'am, kasi may ganitong juicy patient, ganitong oras, these 5 medications kasi polypharmacy na si patient. Which of these medications can be given together? So the action of the clinical pharmacist, especially if admitted na rin si patient, is to review the medication list. So ask for kung kaninong patient ba yun, and then review it, and then determine which medications can be administered together. So to decrease the potential drug-drug interactions. And then you reschedule the time of administration if necessary. And then we advise the bedside nurse, okay, ma'am, ito pong medication, you can give this together with this one. Kasi syempre, as much as possible, we're trying to, if polypharmacy, more or less, every 2 hours ka gigising, pwede, just to give a medication. So instead of that, maybe we can combine or administer medications together, provided again that there are less drug-drug interactions involved. And again, advise nga the bedside nurse of the new schedule if this is feasible. So what is the result of this? The patient has received the appropriate combination of medications at the right time and achieved the patient treatment goals, possibly have avoided adverse effects, prevented medication errors, and reduced the time to reach the treatment goals. Okay. I'll go on to the next slide. So ito yung sinasabi kong how we implement our plan. We use the clinical pharmacist monitoring notes. So ito yung example on both sides. So we have, for example, on the left side, the dose of rosuvastatin based on renal adjustment. So we use the S-bar format. I think in your institution or in Adamson ba ginagamit SOAP pa ba? Subjective, objective assessment plan. So it's almost the same, but ours is S-bar naman. So kahit sa UST ganun din, SOAP din kami. But here, we use the S-bar format, the situation. So you usually use the phrase dose of this medication, frequency of this medication, maximum dose, or just like on the right side, potential drug-drug interaction, and then kung ano ba yung recommendation. Kasi the situation, again, well, I don't want to get so deep into the clinical pharmacist notes because we have another module talking about how we construct or how we draft out our notes. So this is just an example. So we have the background, kung ano yung medication order mismo ng patient, assessment. So again, it will be the explanation or yung observation pertaining to the situation that you mentioned. And then recommendation is the management of the situation. So ito lang yung example. Again, I'll get into it more later on. So we have the functions of the clinical pharmacy. Again, antimicrobial stewardship program. Again, we are part and parcel of the antimicrobial stewardship program. So the program is has these objectives, to improve patient outcomes and decrease healthcare costs. And obviously, our end goal is to prevent or slow the emergence of antimicrobial resistance. Again, we have another module for it naman din later. So for the AMS team, we have for a tertiary hospital like us, we have an IDS as our AMS physician. So this is Dr. Gemeline Garcia. She is our IDS consultant or our AMS chair. And then our clinical pharmacist, since we are almost up to a 300 bed capacity, not exact, we have 3 clinical pharmacists part of the AMS team, myself included. So based on the DOH guidelines, it has to be 1 clinical pharmacist to 100 beds. And then we have an IPC nurse and a clinical microbiologist. Moving on to the strategies, I'll just tackle this real quick, but again, we have another module on it. So these are our strategies that we have implemented for the antimicrobial stewardship program. So we have the pre-authorization and restriction of antimicrobials. We have dose optimization, streamlining and de-escalation, IV to PO switch, 7-day automatic stop order, and audit and feedback. Again, we'll get into the nitty-gritty in the latter part of this session. And these are the examples of pediatric antimicrobials. So we have, monitored and restricted pediatric antimicrobials. So monitored antimicrobials are actually those that are being tracked for their use. And restricted antimicrobials are antimicrobials that require the approval of an IDS consultant prior to dispensing. So what may be, for example, monitored sa pediatric, monitored for adults rather, pwede siyang restricted sa pedia. So it's not necessarily monitored sa adult, monitored din sa pedia. It can be either way, and it can be, we also have antibiotics that are not part of the monitored and restricted antimicrobials, such as, let's say, metronidazole. And for example, for pediatrics, cefuroxime is a monitored antimicrobial, which should require a form to be filled out prior to dispensing. Whereas for adults, cefuroxime is just a watch antimicrobial, or it's not under monitored or restricted antimicrobial. So this is an example of the form that I was mentioning a while ago that needs to be accomplished prior to dispensing. So on the left, we have an example of a monitored request form, and the right shows the restricted request form. So just by looking at it, you already see the difference. So restricted, like I mentioned, it requires an approval of an IDS consultant. So prior to dispensing, they would have to call the infectious disease consultant and ask for approval, especially for the certain indication they're going to use the antibiotic for, and how long they will approve this for. So yeah, that's the difference between restricted and monitored. And more of how the details of the request form, again, later na lang din natin i-discuss. And this is the justification form. So this coincides, or this is in coordination or coordination with the 7-day automatic stop order policy. Meaning, if a patient is to continue a medication beyond 7 days, they would have to have this document accomplished. So they have to indicate the reason, kaya nga justification form. They have to justify the reason why they will extend the antimicrobial therapy for more than 7 days. And again, it will undergo an approval by our infectious disease consultant. Another function is, again, I said we respond to medical emergency codes. So we are part of the rapid response team. So what does the rapid response team do? So when a patient demonstrates signs of clinical deterioration, a team of providers is summoned to the bedside. So again, to assess and treat the patient with the goal of preventing ICU transfers, cardiac arrest, or death. So sinong kasama sa rapid response team? Physicians, critical care nurse, respiratory therapist, and clinical pharmacist as well. So what are the codes that we respond to? We respond to code blues, code purples, and brain attacks. So code blue is when a patient is already suffering from cardiac arrest, pag asystole na siya, kapag kailangan na intubate yung patient. This is our code blue. Code purple, it's when the patient is clinically deteriorating pa lang. So maybe difficulty of breathing or nagsi-seizure. And so yun yung code purple. Brain attack is when the patient suffers from a hemorrhagic stroke. And yeah, so those are the codes that we respond to. So there's an overhead pager that will indicate, okay, sinong patient yung nagko-code. So we have to immediately immediately respond to the patient who is who's called for a code. So blue, purple, and brain attack. We do not participate in silent codes. For example, in the ICU kasi, they practice silent codes since they have intensivists there, and they have stocks of medication that are needed, or they can always order sa chart, and parang mapapaprioritize naman, especially kung nagko-code yung patient. And we have a 2F satellite pharmacy where they can get their medications from, since the ICU is also located on the second floor. So at the hands distance lang naman yung 2F satellite from the ICU. That's why they practice silent codes, as well as the neonatal ICU, cardiovascular ICU, neuro ICU. Also in the ER, they practice silent codes because they have an ER satellite pharmacy din naman dun. Yan. Okay, also I mentioned that we are a provider of medication information. These are our drug information resources. So I asked Ma'am Marge to ask you guys if you guys had access to Lexicomp. Ano ba yung mga references na ginagamit niyo? For example, you mentioned kanina, or you guys nodded when I said SOAP nga yung format nyo. Ano yung ginagamit nyong references? Can I hear one from BS Pharma and one from Doctor of Pharmacy? Ano yung mga references na ginagamit nyo for your case studies? Shall there be any? MIMS lang ba? Ano ba yung mga iba? RxList, drugs.com? How do you guys check for interactions, or is it book-based lang ba? Okay, I have my randomizer. There's a chat. MIMS. Okay, thank you, Ms. Sharon. And Sir Renson is journals. All right, okay. So us kasi, we actually use Lexicomp as one of our major references. Wait, let me just tatarak ko lang yung recipe. Muhammad and Sir Renson. Ayan, Lexicomp. Kasi Lexicomp is like a one-stop shop for us. So it shows the dosings, how it should be administered, ano ba yung concentration dapat ma-target para i-administer. Drug-drug interactions, nandun din. Calculators, for example, to compute for renal adjustment or ALS, advanced life support medications. Ano pa ba? Ideal body weight calculators, nandun na rin. Compatibility for IV lines, nandun din. So it's really a one-stop shop for us. But we don't stop there. We also check for MIMS. We check MIMS, for example, for drug literature as well. For dialysis of drugs, kasi isang homework na pinapagawa sa amin. It's like an extracurricular activity for clinical pharmacists. Again, since we are a provider of drug information, is when they can administer medications during dialysis. And this is our reference, the 2020 dialysis of drugs. So whether, for example, a medication is to be given, or from the reference itself, it says that it is likely to be dialyzed. So what we get from that is you have to give it post-HD or after dialysis ni patient. If it's unlikely to be dialyzed, you can give it anytime. So yun yung mga tinitignan namin. Or sometimes, if walang studies talaga, we check on the pharmacokinetics of the patient, if it's more protein-bound and stuff like that. And also, siguro we check MIMS as well. If we can't find anything from Lexicomp, and we check the drug literature if it's not available in both references. For our neonates, for our specific population or target population of neonates, we use NeoFACS, especially in the neonatal ICU. Our pediatric residents and our consultants sometimes refer to this reference when prescribing medications based on the dosing there, as well as Harriet Lane for our pediatric patients naman. Yun. So I mentioned a while ago nga, we participate in the multidisciplinary rounds in the ICU. So not only do we go on rounds and discuss the cases of the patients in the medical surgical ICU, but also cardiovascular ICU and neuro ICU. And actually, I think last year, ayan, 2 years ago, nakadek kasi kami sa NICU or neonatal ICU. So basically, the neonatal ICU had a solo clinical pharmacy deck on their wards or on their floors ng 8 to 5. So, ayan, so we were able to serve or offer our services to the neonatal ICU by providing medications, by providing medication support system, provide us. Basta we are the medication support system in the neonatal ICU, as well as for patient care. So what do we do as a neonatal ICU-based clinical pharmacist? So yung mga senior clinical pharmacists, sila yung nadedect sa neonatal ICU. First, we create a census of the patients admitted to the neonatal ICU. So, kilala namin kung sino yung rounds namin, sinong mga patients yung kailangan namin i-update bago umakyat, bago mag-rounds. And then, we conduct our AM and PM rounds. So, we conduct our rounds twice, in the morning and in the evening. So, our AM PM rounds consist of checking the patient chart. So, from start to finish, or from last read ng clinical pharmacist to the last order during the AM and PM shift, as well as we do rounds with, or we double check the medication administration record kung tama pa ba yung nakalagay sa MAR nila, tama pa, were they able to give the medication on time, may misdose ba sila, bakit sila may misdose, and for antibiotics, check if kung tama yung bilang nila sa antibiotics nila. So, for example, the antimicrobial day. Kasi in the NICU, sometimes yung mga frequency ng medications nila, since some are preterm, nagiging Q48, Q36. So, minsan, there are discrepancies with the counting of antibiotics. And that's why we're there to validate. And then next, we participate in the NICU-R. Before kasi, every Monday yung NICU-R. So NICU-R is an R dedicated to a certain indication or disease of the day. For example, for this picture, it was on what was this for again? Retinopathy of prematurity. So minsan kasi yung doctors yung nagdi-discuss, minsan yung pharmacist yung instructed na mag-discuss. So on this particular picture, yung pharmacist or yung clinical pharmacist was instructed to discuss the management of retinopathy of prematurity. So the medication for that is Beractant. Now, sorry, not retinopathy. Tama ba? Cervanta. No, I'm sorry. Respiratory distress syndrome. Sorry, Beractant, not retinopathy of prematurity. Respiratory distress syndrome, RDS. So Beractant or Cervanta. So we discussed the pharmacology of Beractant as well as the mechanism of action, the storage, what are the dosings for Beractant, what is the stability of Beractant, and so on and so forth. Part of the NICU-R is also where we go on, parang grand round siya. So you're with the consultant or the attending physician, tapos again, just like the ICU, rounds nyo yung each patient, tapos discuss the case, discuss pang ilang day na ng antibiotic, ano yung suggestions namin, pwede na ba mag-switch from IV to oral, considering that we see the patient and that we really see the progress of the patient, especially from the side notes to the order sheet, to the input-output of the patient, whether the patient was afebrile for this number of days. Maybe that is actually our way of determining whether a patient can shift from IV to oral. So parang ganun. So we have this role to play during the rounds or grand rounds sa NICU. Even questions that come up are like, how do you prepare this medication? How do you calculate the dose of the patient? Are the doses as of today still appropriate for the patient's current weight? Are we still using the birth weight? Are we still using or are we using the current body weight na or current weight ng patient? So those are the things that we consider then, or some of the questions that are asked during collaborative rounds. So you really have to be quick on your feet when answering these questions. We also perform IV infusion rounds. So we compete for total parenteral nutrition of the neonates. And also check if, okay, kapag nag-rounds kami, check if they're still infusing or baka mamaya more than 24 hours na siya nag-infuse, dapat naka-stop na. We check if the rate if the rate na naka-input sa infusion pump is still correct kasi minsan may orders na to titrate kapag ganito na yung feeding ng patient, dapat ganito na yung rate. So you have to check what the current feeding is of the neonate or of the patient, and check if they have revised or titrated the rate accordingly. So that's part of the rounds din sa NICU. And of course, our major role also in the neonatal ICU is the first dose validation. So for the first dose validation, what we do is, of course, first perform appropriateness check, right? So once the medication is with you na, and then you're going to administer, the nurse is about to administer the medication, you of course check IPSG-1 if for the patient demographics, tama ba yung na-dispense ng IPD, tama ba yung na-compound ng compounding pharmacist, tama ba yung label na nakalagay doon sa medication, tama ba yung sticker na pinrovide ng inpatient pharmacist or compounding pharmacist, is it the same as of what was ordered? And then may read back process. Okay, so for patient, ganito, ganyan, hospital number, ganito, ganyan. For example, for this is D50 water 15 ml. So, and lahat ng components ng TPN nandun sa mismong label dito sa bottle na to. So again, it depends who will read back. It can be the nurse, it can be the pharmacist. So mas maganda yung nurse yung mag-read back ng mismong order tapos i-check. Or yung pharmacist yung mag-read ng order and then yung nurse yung mag-check ng label para walang bias. Ganun. So check if tama ba sterile water 76.4, sodium chloride 3.8, ganito ganyan. All to run for 3.3 ml per hour for 24 hours. Kung okay, no discrepancies, go to the patient. Again, IPSG-1, check if that is the patient that you have to hook this total parenteral nutrition to. And then, okay, they will prime the tubings and then administer it na. So you have to check kung tama din ba yung inilalagay na rate sa infusion pump. So that, and this doesn't only apply to total parenteral nutritions, but also medications that are to start. So lahat ng mga to start medications, we perform first dose validation to ensure na okay, tama yung pag-prepare, tama yung inaspirate the volume, tama yung patient na in-administeran niya, tama yung rate of administration na binigay niya yung certain medication niya. Yeah, so those are the things we take into consideration when validating first doses. Right now, I said before, di ba, na may naka-deck talagang or naka-deploy na clinical pharmacist sa NICU. Ngayon kasi wala na because our manpower is down to almost half. What we're doing now is first dose validation na lang. So wala nang naka-deploy doon as of the moment. But all of the medications that are to start, umaakit kami to perform first dose validation. And one of our achievements or one of the things we pride ourselves on is since 2 years ago, or at least once we started nung, 2 years ago sa NICU, parang 6 months to a year din silang medication error-free. And that is one of the things we pride ourselves on as clinical pharmacists kasi nahaharang namin, nakakatch namin, and ayun, because of the first dose validation, it did wonders when it came to being free of medication error. Yeah. So, that ends my first presentation. Do you guys have any questions for me? I know this went by real fast. I think I talked for about an hour for this presentation and I don't know kung nire-wrap ko ba. So let me know if you have any questions about the overview of the clinical pharmacy practice. So yun nga, today nagsabay yung interns and clerks. So again, it's important kasi also for our interns or our BS pharmacy students to know ano ba yung mga responsibilities ng iba't ibang units. And for this day, yun nga, clinical pharmacists. And hopefully, this first session was able to inspire you probably to take up clinical pharmacy or pursue doctor of pharmacy. Ayun. So any questions for me for this first session before we go on siguro for a 5-minute bladder break? Kasi yung next topic natin is more on the medication appropriateness check na talaga. Any questions? Ayun. I don't know how this works. Do you guys turn off your camera lang for 5 minutes or do you re-enter the Zoom? chat na lang. Zoom room. Nandyan ba si Ma'am Marge? Ma'am Marge? Wala si Ma'am Marge. Okay. So, I think you guys can stay on and then just come back after 5 minutes. Mga 11:07, then we'll discuss the next topic na if there are no questions. Alright? There's a chat. Hi, Ma'am Ange. Pwede po ba pa-recap lang dun sa part ng may brain attack? Okay. Thank you, Sir Renson. So, for brain attack kasi, these are the patients suffering from a hemorrhagic stroke. So, the purpose of it, why we respond, is kasi meron kaming daladalang Actilize. Actilize is to, it's an alteplase. So, wait lang ha, let me check yung MOA. I'm not actually so sure. I don't want to make something up. Actilize. Ayan. It is, ayan pala, sorry, antithrombolytic. So, meaning, yun nga, this is the drug of choice when a patient suffers a hemorrhagic stroke. And kami yung nagdadala nun. But if the patient is admitted sa floors, yun lang, dun lang kami nagre-respond. But for calls of brain attack in the ER, yung pinaprovide namin is a dilution guide. Kasi this is weight-based. It would depend on the weight of the patient kung ano yung dose na ibibigay. So we provide a guide on how to first prepare the medication, what to aspirate based on the, again, dosing of the patient, how long to infuse it for, and the stability of the medication. So an example is, for example, may nag-call ng brain attack sa ER, yung pupuntahan namin is yung CT scan, which is the radiology department. And that's where we meet with the neuro resident on duty and the nurse, and we calculate together na, okay, tama ba yung kinompute namin? And then they will also calculate, and then pagtutugma, okay, tama. Then we leave the dilution guide with them. The medication will come from the ER kasi, especially yun nga, kapag kinol sa ER, diretso na sila with the medication to the CT scan, where it is ideal na doon nila ibibigay depending on the results of the CT scan, kung kailangan mag-thrombolize. So, ayun, I hope that answered your question. We serve as more of validating the computation of the dose of the medication. And yun lang naman yun. That's why we respond, kasi they need validation or they need help when it comes to the computation of the dosing. Yan. Did that answer your question, Sir Renson? Kasi he chatted it lang. Thank you. Any other questions? None? Okay, so 11:10 we'll be back. You guys can turn off your cameras, and then by 11:10 we'll start medication appropriateness check. Hopefully in time for lunch. Before lunch, we'll finish before lunch. All right, okay. If no more questions, I'll see you at 11:10. Thank you. Ayun, so welcome back. Are you guys there? Were you able to get a bladder break for the 5 minutes? Or drink your coffee? If I'm a little boring, I understand that this is more on lecture and I know you'll be able to apply more pag naka-deck na kayo dito sa on-site. So I hope this will be part and parcel of what you will take into consideration pag nagjo-duty na kayo. Yun. So again, this is more theoretical and I know most of you baka mas mabilis matuto kapag hands-on. Again, this is just to give a brief background on the clinical pharmacy practice. So yun, nagkakape na si Sir Cyril. Sorry na. Medyo. At si Sir, sino yung nasa Starbucks? Si Sir Renson, okay ba dyan? Malamig. Yun, okay. So I guess I'll start. All right. So moving on to the medication appropriateness review or our CPMAC, medication appropriateness check talaga siya sa amin. So medication prescriptions or orders are reviewed for appropriateness. So it includes the 2 reviews. So good medication management includes 2 reviews of each prescription or order. Wait lang ha. So the 2 reviews include the appropriateness of the medication for the patient and his or her clinical needs performed at the time the medication is prescribed or ordered. So like I mentioned a while ago, di ba? Part nga yung monitor and evaluate kasi what we do is to check if the medication is appropriate at the time the medication was prescribed. But the next day, maybe it might not be appropriate anymore. So that's why we continue to monitor and evaluate every day kapag nakakapag-update kami ng patient profile. And then the next review is the verification at the time of the administration that the medication is or exactly as ordered or prescribed. So more on the nurses naman to or sa amin, sa NICU, when we do our first dose validation. So what are the elements ulit ng appropriateness review? What are the elements we consider or the criteria we consider when deeming medications appropriate? So it includes the evaluation of the appropriateness of the drug, dose, frequency, and route of administration. So basically, the elements of a complete order. So I think na-mention naman sa inyo during your past few days of orientation, yung elements of a complete order. Again, the drug, whether so generic, kung may brand naka-enclose in parenthesis, then dose, the frequency, the route, kahit nandun yung formulation na tab, kailangan pa rin ng route kasi it could be given per orem, it can be given via nasogastric tube, via PEG, via J-tube, via G-tube, and all. Or baka meron talagang, for example, it's just a medication and it's available in IV and oral form. This is why there's an the route is important as to what to dispense, what is intended by the physician. Yan. And then therapeutic duplication. For example, 2 NSAIDs are on board. Ito yung usual na encounter namin kapag post-op yung patient. So, may order yung anesthesiologist, may order din yung surgeon. Minsan pare-pareho, iba't iba yung NSAIDs na on board. So, multiple NSAIDs are on board. So, what we do is we call or we text the surgeon or the anesthesiologist regarding clarification on whether or not they will be given the patient will be given all of these NSAIDs concomitantly. And usually they reply na, okay, defer my order, ganito, ganyan, or follow the surgeon's order. So then we'd have to have it documented on the chart na to defer the anesthesiologist's order. And then, that's what the inpatient dispensing pharmacist will transcribe, and that's what we will review for appropriateness. Then real or potential allergies or sensitivities. So like I mentioned, for example, a patient is allergic to, actually we will be discussing each sa following slides. So ayan, real or potential interactions between medications and other medications or food. So drug-food interaction. Variation from hospital criteria for use, like I mentioned, compassionate, off-label, non-formulary, patient's weight, and other contraindications. So the appropriateness of the drug, dose, frequency, and route of administration, this is also based on the indication or disease. Kasi a drug can be used for multiple indications. So and also based on age or based on indication and disease. So for example, dose, if patient is suffering from chronic kidney disease or acute kidney injury, baka kailangan ng adjustment. So yun yung appropriateness ng dose. And also frequency, sometimes frequency lang yung nagbabago when it comes to adjustment sa renal dose, renal dose adjustment. Then based on age, sometimes for pediatrics and adults, maybe it's not appropriate, maybe the certain medication is inappropriate for pediatric patients based on based on the recommendations of the manufacturer, based on weight, of course, during pediatric dosage calculations, or if the patient is obese or malnourished. So sometimes you have to use the ideal body weight in order to get the target prescribed or target recommended dose, based whether or not the patient is female or male, risk factors, electrolyte imbalances, or whether the patient is a geriatric and all that. And based, of course, on the clinical status of the patient or the current health state of the patient. Next, we have pediatric dosage calculation, which again, like I mentioned, it's based on weight. So most drugs in children are dosed according to body surface area or body weight, usually milligram per kilogram. And again, like we did in the previous presentation, care must be taken to convert body weight from pounds to kilograms. Minsan kasi kapag hindi updated sa system yung height and weight, nakikita nyo either kung not available yung information, sometimes it was the height and weight taken from 3 years ago, so that's not reliable anymore. So we call for the updated height and weight, and sometimes they give it to us in pounds. So kami pa yung magko-compute, or they give the height and feet in inches and you have to compute for centimeters. Doses are often expressed as milligram per kilogram per day or milligram per kilogram per dose. So sometimes when they order, for example, Cefixime, like a while ago, 2 ml PO every 12 hours, 8 mk day. Or minsan 8 mkd lang yung nakalagay. So ano ba, 8 mkd ba yung gusto ni Doc, or 4 mk dose, or 8 mk dose? So this would require further clarification from the prescriber. Kasi minsan, nilalagay nga nila 8 mkd, pero hindi siya equivalent dun sa dose na pinrescribe. Like for example, 2 ml every 12 hours. Tapos nilagay niya 16 mkd. Eh, hindi naman 16 mkd si patient. So ano ba talaga yung target nila? 16 mkd ba? Or yung mismong order na 2 ml every 12 hours? So there has to be congruency of the target or prescribed regimen, the prescribed regimen and the target na dose or target dose per day. Yan. Therapeutic duplication naman. So these are examples of therapeutic duplication. So for example, ampicillin, sulbactam, and cefuroxime. Can someone tell me why you think this is a therapeutic duplication? Or maybe you can tell me, no, Ma'am Ange, it's not a therapeutic duplication. Baka mali lang yung nilagay ko. Maybe this is just a test. Or, so can anyone tell me or share your thoughts why you think this is considered a therapeutic duplication? I'll get someone from clerkship or from our pharmacy Farm D students. Si Miss Cleophas. Am I saying that right? I saw her a while ago eh. Ayan, si Miss Leo May Cleophas. Are you there? Hello? Okay, she is not here. Next is, yan, si Miss Ken Lalikan. Ikaw yung pinili ng ating randomizer.
Kasi same po silang beta-lactam antibiotics. Yung Ampisul po, penicillin po siya. Tapos yung cefuroxime naman cephalosporin po.
Okay, thank you, Miss Ken. So tama, so they share the same structure kasi they both have the beta-lactam ring. So it's possible na they have, no, it is these two antibiotics have the same coverage. So if they're used together, one, it's not cost efficient, and two, you're giving the same two different classes of antibiotics, but under the same family, so under the same structure, beta-lactam inhibitors. So, so tama, ampicillin, sulbactam, and cefuroxime. So these are the things that you have to take into consideration. They have the same coverage, so why would you give two antibiotics that would cover the same, for example, indication, or same growth, or same culture, or same growth? And then next we have amlodipine and verapamil. Anyone would like to share? Again, si Sir Bryce. Sorry, si Sir Bryce yung nauna, ma'am. Game.
Same po sila na calcium channel blocker po. CCB po pareho.
Thank you, Sir Bryce. And sino yung nag-raise ng hand kanina? I have a question for you naman. Sino yung nag-raise ng hand? Si Ma'am Kat ba? Hindi, Ariana. Si Ma'am Ariana, nandyan ba? Ano ba yung sinabi ko? Ariana, saan na siya? Nawala na siya. Ano ba yun? Miss Ariana Sanchez? Are you there? Ayan, nahiya na siya kasi may follow-up tanong pala. Sige, Sir Bryce, ikaw na lang since ikaw nag-mention na dalawa silang CCBs. Di ba we have two types of calcium channel blockers? Would you be able to identify amlodipine, the type of, or the specific type of calcium channel blocker ng amlodipine and verapamil? Or since you answered, sige, ikaw pumili, sino ba yung sasagot?
Ma'am, ano po una? Si Sanchez po, ma'am, nawala daw po yung Zoom niya kanina.
Ay, okay, sayang naman. Okay, sige. Can you answer my question or do you want to pass it on? Do you want to call a friend?
Amlodipine po is dihydropyridine.
Yes, tama.
Tapos
And then
yung
verapamil.
verapamil naman po is kalimutan.
Okay lang. So, tama. So, thank you so much, Sir Bryce, ha. Dihydropyridine, and then yung verapamil is non-dihydropyridine. Yun lang naman yun, sir. So, yung mga mnemonics naman natin is, okay, so yung dihydropyridine, so these are those calcium channel blockers that end with INE, while non-dihydropyridines have no INE ending. So yun yung mga verapamil, diltiazem, yun. So what are the difference between these two? Yes, they are both calcium channel blockers, but there are actually, based on experience, some certain scenarios or some cases, parang isolated cases na ginagamit pareho. But depending on the case, this is usually considered a therapeutic duplication. Bakit? Amlodipine kasi, it has more effect, or dihydropyridines in general, like amlodipine, felodipine, nifedipine, nicardipine, they have more effect on vasodilation and less effect on the heart function. And then verapamil kasi, yung mga non-dihydropyridines, they have less effect naman on vasodilation and more effect on cardiac function. Yun. So those are for the calcium channel blockers. Thank you so much, Sir Bryce. Ayun. So how about for budesonide and formoterol and fluticasone and salmeterol? Ayan, si Miss Leo, you're back. Game. So what
Sorry po kanina.
therapeutic duplication?
Parehas po silang steroid inhalers po.
Yes, steroids, yung budesonide and fluticasone. Thank you. But not only that, they are also yung formoterol and salmeterol. Ilagay ko lang yung ano dito. Yeah. Formoterol and salmeterol are long-acting beta-2 agonists. Pareho silang LABA, di ba? May SABA tayo and may LABA tayo. So formoterol and salmeterol are long-acting beta-2 agonists. And if given together, they may enhance the adverse or toxic effect of each other, of another long-acting beta-2 agonist, meaning possible mag-develop ng sinus tachycardia, magkaroon ng hypokalemia. So these are the things that we consider, or these are the things that would trigger us to refer to a doctor. But first, this is only based from lexicon, from our references. But again, it's a case-to-case basis. You always have to check other journals, other articles. Maybe pwede talaga, baka may studies na pwede sila ipag-combine. But these examples, hindi talaga siya recommended. But then again, yung sinasabi ko, don't always rely on one reference. Always search. Always adjust to the physician. Always adjust to their orders and check talaga. Maybe they really did see an article or see a journal like Sir Renson was able to say na you guys also based from journals. So, ayun. So, always check your references. Always exhaust all the references and resources before referring. And study the case of the patient before referring. Ayun. Maybe intended yung interaction na magpro-provide ng dalawang medications when given together. Yun. For real or potential allergies or sensitivities, we have, for example, for penicillin allergy, if a patient is allergic to penicillin, tapos pinescribe ng IV, ampicillin sulbactam, or IV, coamoxiclav, what do you think could be your recommendation as a pharmacist? Kunyari, ako yung naka-receive ng ako yung IPD, nakita ko sa Orion or sa system na patient is allergic to penicillin, yet na prescribean ng ampicillin sulbactam 1.5 grams IV Q8. Papago niyo ba yung medication? So yun yung first question ko. And yes, Miss Ken. Ayan, alam na to ni Miss Ken kasi bakit? Game Ken.
Kasi lagi nababalikan ng PDR. Hindi,
Oo.
ma'am, ano po kasi, yung sabi po ninyo, i-confirm kay doctor first kung ano po. Syempre, i-inform po yung case na allergic si patient dun sa antibiotic po na yun. Tapos, same family sila. Tapos, alam ko po nagsasuggest ng skin testing. Tama po ba?
Tama. Skin test or test dose. Yes, correct. So thank you, Miss Ken. So as an inpatient pharmacist, you have to be able to filter out, or at least for clinical pharmacists as well, minsan na-overlook ng inpatient pharmacist. So napupunta sa CP. So we have to be able to filter out as inpatient pharmacists kung ano yung mga allergies ni patient and ano nga yung prescribe ng doctor. So again, I'm saying this again because everyone has a role to play in patient safety, not just because sine-check namin for appropriateness, hindi nyo pwedeng i-check. You also have a role to play in determining appropriateness. So, sa inyo pa lang, okay, allergies, penicillin, pero nag-ampicillin sulbactam. Hindi lang kayo, okay, ampicillin sulbactam, not giving any care about the allergies of the patient. So, it's not like that. So tama yung sinabi ni Ma'am Ken. Okay, we call the nurse or we call the doctor. We can explain that the patient has allergies to penicillin and is prescribed with ampicillin sulbactam. We may recommend to perform skin test or test dose to deter. Kasi yung goal naman natin dito is to prevent an anaphylactic shock or a sentinel event from happening or additional drug therapy kapag kunyari magkaroon ng reaction yung patient, especially cross-sensitivity reaction with the same family, yung penicillin nga. So maybe if we did not perform that skin test, baka magpa-diaphin pa tayo, magpa-epi pa tayo, full-blown anaphylactic shock. So mag-epi, famotidine, hydrocortisone, lahat yun. So nag-add ka pa ng cost kay patient instead of being able to rule it out first if the patient is allergic or not to ampicillin sulbactam. So skin tests are used to find out what might be causing, again, an allergic reaction. So this is an intradermal test. Also, yung test dose na sinasabi ko kanina, test dose procedure kasi involves the IV administration of 10% of the total dose ng patient given as slow push over 5 minutes. So, i-monitor muna kung may experience or nakaramdam ng reaction, na-observe na reaction kay patient. And if not, you can infuse the rest of the antibiotic or 90%, the remaining antibiotic over 30 to 60 minutes. So it should be noted that some patients will not respond to the test dose, but some actually experience an adverse reaction to the full dose. So you have to check reactions to both the 10% and the 90% prior to continuing the medication per se. So what is the algorithm for allergies? Yun, we can suggest for skin test. If the patient or if the doctor does not want to proceed with a skin test, they have to note it on the chart or at least beside the order since nag-ampicillin sulbactam sila on the side notes. Mag-document lang sila ng noted with allergies on penicillin kasi we have to have that documentation. Aware sila may allergies yet they're giving this antibiotic that could possibly cause again a reaction to the patient. So that's one, skin test and test dose. Skin test and test dose. Paano kung oral, for example? Ayan, so penicillin allergy ulit, tapos nagbigay ng cephalexin, Q6, for example. What do you, oral cephalexin every 6 hours. What is your recommendation as a CP or as a pharmacist, sorry? What do you think you can ask for? Or ano, ipapago mo na lang ba? Kasi hindi ko naman kayang skin test yung oral eh. Hindi ko naman pwedeng i-test dose yung oral. Kasi this only applies to intravenous medications. Anyone? I will try. No, don't worry. This is just to parang get your mind working and think, oh nga, what will I do? Paano kung cephalexin? Bayanan natin? Bayanan lang natin si patient? Oral naman yan eh. So ito, si Sanchez. What's her first name? Ayan, si Ariana. She's here na pala, di ba? Ariana, are you here? Favorite ka na.
Ano po, ma'am? Mag-change po siguro ng antibiotic na
Change to a different antibiotic. Tama?
ma'am.
Yeah. So, thank you, Miss Ariana. So, actually, for example, in this case, na patient is allergic to penicillin, tas magbibigay ng oral penicillin or cephalosporin. Yung algorithm kasi natin dyan is to always confirm if the patient has taken this before. If the patient has, ano ba to? Remove pin. If the patient has taken this before, if the patient has taken cephalexin before, for example, and if nakapag-take, edi ipa-monitor na lang again for possible cross-sensitivity reaction due to the patient's allergies. So not necessarily shift to a different antibiotic, but first check nga if the patient has taken this before. If not, then monitor for possible hypersensitivity reaction. Yun. But if the problem is that the patient has taken this before pala, nung na-interview ng nurse, tapos naka-experience ng reaction, that's the time maybe we can consider mentioning to the physician that the patient has taken cephalexin before and has allergies to penicillin and has experienced this sort of reaction with cephalexin previously. So maybe recommend to shift to a different antibiotic, ganyan. So yun, that's yun yung algorithm. I hope that made sense. And for sulfa drug allergies, kunyari, yun lang, yung allergies na lumabas is sulfa containing drugs. So you have to be careful of cotrimoxazole, dapsone, furosemide, celecoxib, and glimepiride kasi meron silang sulfa bond na sa structure nila. Sulfahydryl bond. Ayun. Sulfahydryl ring, sorry. And then for real or potential interactions between medications and other medications or food. So an example is drug-food interaction. So this is the very, very famous warfarin vitamin K. Can someone explain to me kaya why do you think these two have interactions or how these two are related in a way? If no one, let's choose my randomizer. Nakakabahan na ba kayo? Ito na. I don't know how to pronounce your last name. Miss Sam, sorry. Miss Sam Mantha. Are you there?
Good morning. Good morning po, ma'am. Yung sa warfarin and vitamin K po, may interaction siya kasi yung vitamin K, nagpo-prolong siya nung pag-form ng clotting or blood clotting.
And warfarin is? Yes, Miss Samantha. Warfarin.
Yung warfarin po is yung drug to prevent blood clotting po.
So thank you for that. Someone chatted. Anticoag. So yes, thank you, Miss Chaya. So yeah, vitamin can change how warfarin works, and this changes your international normalized ratio or yung INR mo. So vitamin K, it lowers yung INR mo. So the lower your INR, the less time it takes for your blood to clot. And vitamin K, like they say, normally helps your blood clot, so wounds don't bleed so much. But yung warfarin nga is an anticoagulant that will make you bleed and dissolve the clots nga. So warfarin interferes with the action of vitamin K and therefore prolongs the time it takes to form a clot. Does that make sense? So, di ba kasi, if I'm not mistaken, vitamin K is the antidote for warfarin overdose, right? So, yun kaya nga they're opposites. But, what if you have a patient that eats a lot of leafy vegetables? Kasi yun nga, vitamin K containing food, for example, yan. Broccoli, cabbage, lettuce, you can't ask them to stop the way they're living or stop the way they're eating. But what you can counsel them on is to say that yun nga, it's important to keep it in balance. So it's important that you don't suddenly eat a lot more or a lot less vitamin K rich food than you usually do. And of course, again, this has to be explained to your patient, either ikaw or ng physician. So yun yung interaction ng warfarin and vitamin K. So ito yung mina-mention ko na reference namin before, the drug interaction analysis. So drug interaction analysis on our Lexicomp reference. So as I said, sa Lexicomp, we have yun nga, yung drug, dose, frequency, appropriateness of medications, or yung recommended dosing of medications. We have the tricels, IV compatibility, and the interactions. So here kasi, this is quite small, pero you can see here that you can input all the medications on board ng patient, and it will filter out kung ano yung mga category D, category B, category C. So yung mga notes na sinesend namin or yung worth referring, yung mga significant interactions lang. Category D, which would mean that you have to consider therapy modification, or maybe you have to separate the time of administration, or maybe you just have to monitor the therapy. And category X, yun yung mga mag-avoid combination. But we don't really recommend to avoid combination kasi if hindi siya, kung kailangan talaga yung ganong medications together, yung specific medications that have that interactions that have to be avoided, you have to recommend an alternative, or at least monitor for something, monitor for adverse effects, or kung ano yung ma-enhance na adverse effects of that, for example, interaction of the two medications that will interact. Gets ba? So yun, category D and category X na interactions yung nire-refer namin. And also, here sa interface na to, you can also see ano yung mga duplication of therapy. Yan. Next is we have the variation from hospital criteria for use, like I mentioned, off-label use of drugs, and what was, I think, discussed the past few days is compassionate use of unregistered drugs and yung mga non-formulary. So I'll discuss more on off-label. So yung off-label kasi, it is when the medicine is prescribed or administered for another indication at a different dose or another route of administration, and for a patient of an age, for example, pedia or adult, or gender outside the registered use, based on, let's say, drug literature, especially, for example, diazepam. We have an intravenous diazepam kasi. But for pediatric patients, it is given per rectum, especially for frank seizures, para mas mabilis yung absorption and mas mabilis ma-handle or ma-manage yung seizures. So, but again, based on the drug literature of intravenous diazepam, again, it is approved to be used intravenously. Yet, our prescribers, based on clinical evidence, it can be used per rectum. So, yung solution, ng intravenous solution ng diazepam will be flushed per rectum to the pediatric patient. So, that is the off-label use. So, where do clinical pharmacists come in here? So here, they check the consent form, that the consent form is duly accomplished, and that evidence muna has been reviewed. Kasi, porket may off-label, hindi hindi porket may off-label consent form, papago na namin agad. Hindi. So we have to check mamaya kasi we have to check for clinical evidence showing that this medication can be used this way and is safe, still safe for the patient. But a consent form must still be filled out again kasi consent form nga, you have to get the consent of either the guardian or the patient, him or herself, that you will be using this medication that is not approved for this use and use it as an off-label, for example, via per rectum, off-label route. But rest assured that this is that's why nakalagay dito yung justification for use kasi it has a faster absorption per rectum, especially for pediatric patients. Now, for example, ayaw magbigay din ng IV, they'd rather flush it per rectum. Ganun. And as well, it manages the seizures abruptly. Ganun. So that's the role of clinical pharmacists in the off-label use of drugs. For patients' weight and other physiological information, again, this is needed to calculate the creatinine clearance, the GFR, and other physiological information such as liver enzymes, CBC, so RBC, WBC, hemoglobin, and platelets. For example, my dengue patient, you would be able to check on the progress of the patient or the clinical status, not really clinical status, the progress of the patient, whether, or the trend rather of the platelets, kung nag-increase ba siya, kung may kailangan pa bang, kung kailangan pa ba ng blood transfusion, kailangan pa ng additional drug therapy, depending again on the different information made available to you. Yeah. For AKI, I think this has been discussed during your pharmacology din naman, more on the clinical manifestations and yung mga staging, but I won't go much into it naman. But these are the signs, or these are the symptoms, the signs and symptoms resulting directly from diminished kidney function. So you have edema, hypertension, decreased urine output, or in severe AKI, anuria. Again, you have to take into consideration that many patients have no clinical symptoms and an increase in creatinine is detected by laboratory tests that again are routinely obtained among hospitalized patients. So sa amin, kapag may abrupt decrease or increase sa creatinine clearance in like just a day or two, it cannot be used as an indicator to adjust the dose or frequency of the medication agad. So kailangan we give it as much as 48 hours bago mag-resolve or bago mag-refer kay doctor kasi usually in 48 hours dapat mag-resolve yung AKI if there are no more underlying conditions. So again, this is what hindi porket we consider renal function as basis for referral. You also have to check baka the patient is suffering from AKI. Anong stage? Tapos, or CKD na pala siya. Hindi na kailangan ng referral because benefits outweigh the risk. So it's something, those are the, again, criteria that you have to take into consideration when deeming the dose and frequency of a medication appropriate. Even the drug, maybe yung drug mismo contraindicated kapag CKD na yung patient. So yun. For chronic kidney disease, this is the presence of kidney damage or decreased kidney function for 3 or more months, irrespective of the cause. So these are, I'll just discuss briefly or just flash on the screen nga kung ano yung mga stages. So this is very important to know that yung mga 1, 2, 3A, 3B, 4, and 5, and yung corresponding niyang GFR levels. And yung terms, kung greater than 19 GF or more, the normal lang naman yung kidney function mo. But if it's less than 15, you might need to undergo dialysis na. So yun. This is an example of the interface kapag tumitingin kami ng renal adjustment. And this is specifically for PIPTAS or piperacillin tazobactam. For example, the patient is prescribed with piperacillin tazobactam for hospital-acquired pneumonia, for example, with growth of Pseudomonas aeruginosa. So yung usual recommended dose is, kasi makikita nyo dito, ang daming columns, saan ba ako titingin? So you look for, if the usual recommended dose is 4.5 Q6, which it is for HAP with the growth of Pseudomonas, dito ka titingin. Ngayon, ito yung CREA na titignan mo. Okay, saan ba pumapatak yung CREA or EGFR ng patient? If dito, kunyari, 33, 34, yun yung CREA eGFR ng patient, you can decrease to 4.5 Q8. But it's not because, again, na yung renal function dictates na 4.5 Q8 na yung ibibigay mo. I-decrease mo lang yung frequency. What if the patient is patient's CBC or patient's white blood cells are yung trend niya pataas ng pataas? Why would you still decrease the dose? Not unless you give a disclaimer na yung basis mo lang is renal adjustment or yung creatinine or yung renal function ng patient. Yet, increasing pa rin yung trend ng WBC. However, you see that there is regressing pneumonia on the chest X-ray, for example. Then maybe you can consider that as an indicator na, okay, so regressing naman siya. Maybe we can consider decreasing the frequency of piperacillin tazobactam to Q8 since umi-epekto na yung Q6 eh. So, okay, let's target the renal function. Since nagre-regress na, babaan natin to Q8. So that's something you can think about as well when referring to the physician about your recommendation. Yeah. And also, iba naman siya kapag hemodialysis yung patient. If the patient is undergoing, for example, 3 times weekly na hemodialysis, 2.25 Q8 na lang yung ibibigay mo or yung magiging recommendation mo. So, something like that. That's how you view the renal adjustment or view yung interface na to and interpret it in your way of analyzing yung case on whether or not to refer the medication. Next is other contraindications. So we have, for example, trimetazidine. So trimetazidine is for unstable angina, usually, and for creatinine clearance below 30 ml per minute, it is contraindicated to be used. But instead, what we do is, yes, it's contraindicated, but do we have an alternative? For example, ranolazine. It also has a renal adjustment. So what can we do? So we can either ask them to monitor for chest pain, but actually, for trimetazidine, it has cardioprotectant properties that are better to be given, especially parang benefit outweigh the risk na lang yun eh. Kapag nag-hemodialysis na si patient, kapag CKD na yung patient, parang the benefits outweigh the risk of giving trimetazidine. So yes, it is contraindicated. However, there are journals stating that there are cardioprotectant properties when used for patients with creatinine clearance below 15 or patients on hemodialysis. Yeah. But what we try to do is to ensure that at least it is in the least possible dose. So domperidone naman is known for QT prolongation. So when alone, it can cause QT prolongation, but also it can significantly increase when the risk of QT prolongation can significantly increase when because it has a lot of interactions with different medications. So that's also what you have to take into consideration. Or if the patient is already experiencing QT prolongation, it's better not to use domperidone. So again, it's time to look for alternatives. Ano pa ba yung mga prokinetics na pwede ibigay natin that are less likely to cause pure QT prolongation? And then for pregnant women or pregnant population, simvastatin is also contraindicated. So ano ba yung first line natin for hypercholesterolemia for pregnant women? So it's usually yung mga bile acid sequestrants, yung mga cholestyramine, cholestyramine. Yan. So those are yung mga recommendations that we can give. But also, take into consideration when you recommend, dapat meron tayo dito sa Philippines or meron din tayo dito sa pharmacy kasi we might be able to recommend pero wala naman tayong mapro-provide na medication. Kung walang alternative, then monitor the therapy na lang. Ganun. And for my last slide, before we have early lunch, or if you don't have any questions, the pregnancy risk category. So again, important for our pregnant population, always check, especially on our 5th floor. These are genesis areas here in the hospital, ang mga birthing units natin. You have to check the medications prescribed and cross-check it with the pregnancy risk category and recommend as needed. For example, category X. For example, levodopa or Levopron, an antitussive. It is not recommended to be given to pregnant patients. What can we give in what can we give as an alternative as an antitussive for dry cough? Maybe what we usually recommend is butamirate kasi it is safer for pregnant patients. So yun, that's what we usually refer to our OBs when another attending physician prescribes Levopron. So yun, that's an example of giving an alternative depending again if the medication prescribed is not safe for the patient. So that is my last slide. Anyone have questions or clarifications that you guys want me to go back to? Maybe in the chat, or maybe you can raise your hand. If not, I will be the one to ask questions before we end the second presentation. I will stop sharing. Yeah. Any questions from the group? From either our PharmD students or our BS Pharma students? Wala? Ako na lang magtatanong. Okay, sige. Let's try. Ano ulit yung ating algorithm for allergies, especially yung mga interns first day nyo tomorrow. So, madedect na kayo or mapiprecept kayo ng mga senior inpatient pharmacist or junior inpatient pharmacist